Good morning. I think you see my introduction over there. In 2017, Somali region of Ethiopia. How many of you heard about this? It's a place in a country called Ethiopia. Ethiopia has got a Somali region. There is a country, Somalia, also just adjoining to this Somali region. So there are altogether 11 districts in Ethiopia. Out of that, one is Jarab zone, they call it. So it borders with Djibouti, Somalia, and Kenya as well. It's a very remote place of this earth. It's a desert. Scarce vegetations are there. Very scanty population are there. So in that place, people are of still a nomadic kind of people are there. They keep on traveling from one place to another in search of greener pastures. They raise cattle, so they need green pastures to feed their cattle. That's how they move on. Keep on moving their whole life. So at that place, if a cholera epidemic happens, what will be the situation there? Government is far away. The international organizations, UN organizations are also far away. So in such cases, I was deputed as WASH, that is Water Sanitation and Hygiene expert in this remote area. 6.66 million population is there in this area. And this area is almost 3 times the area of Nepal. It's a region of one country, but 3 times more area than Nepal. But the population is very low, 6.66 million only. 11 zones, 4 townships were there, and 4 districts: Dagapur, Gunagado, Yukale, Daksamado. So my station was Dagapur. It was year 2017. If you look into AI or internet, then you can find out there was a cholera epidemic in 2017. 6,500 cases altogether in the whole region of 6.6 million people. 56 deaths altogether. This was the picture of those cholera treatment centers. There were no cholera treatment centers before that cholera epidemic. It was WHO who provided funds, who provided material, who provided doctors, nurses, and everyone. And then they established this cholera treatment centers, CTCs. And my duty was to go around these 4 different CTCs and just try to manage their waste. You people, health professionals, you created waste, okay? And I was the one who had to manage that. So it was interesting. Please, next slide. Okay, liquid waste management. What was to be done there for liquid waste management? First one, all the wastewater from showers, and then sinks, laundry, and hand washing points were collected in waste dumps and directed to soak-away pits. These soak-away pits were such designed that they were at least 35 meters away from any water points. So that's how we segregated the waste and the water, the intake of water, the source of water. Second one, excreta. Stools and vomit were collected in buckets because the patients, cholera patients, were not able to go to the toilet by themselves. So they had to do all those excretion as the bed only. So they were collected in buckets. That bucket already had a 0.2% concentration chlorine liquid in it, so that all the pathogens, those come out of your vomit or stool, they die off there because of that chlorine concentration. So if you ask me how much is 0.2% chlorine, then anybody can tell me how much is 0.2% of chlorine solution? Sorry? In 1 liter, how much? In 1 liter, how much chlorine is 0.2%? 2 milliliters, okay. Yeah. Then the drainage, proper drainage system were organized all around those camps, and then balanced places, no stagnant water should be there. So this was ensured. Because it was a desert, so scanty rainfall was there, then it was not a big problem. Next slide, please. Okay, then solid waste management. What we used to do for the solid waste management was soft waste, general waste, and organic waste. First of all, the soft, there were those boxes. When they were 80% full, it used to be closed and kept aside in a particular place. It was like a bunker below the ground. It was watertight. No water could flow in and flow out of that chamber. Likewise, the soft waste, there were infusion bags and used compressors. They were burned on site. Incinerators were there. I've seen many incinerators in many hospitals, and most of them, almost 90%, are not working properly. Just because of one thing. The incoming air is less in the burning chamber. So please ensure whenever you are interested to build an incinerator somewhere, then please make sure that the outgoing area should be half of the incoming area for air. Okay? If you make sure of that, then your incinerator is going to work. Then waste bins were there for general waste and organic waste like placenta and others. There were bins and food waste bins, and those were also watertight. No water, no liquid from that would reach into the surrounding underground water, so that was natural. Treatment and disposal. This incineration, high temperature incinerators used to destroy the precious waste, incinerators become non-hazardous. This is the best way of treating waste. But please make sure that in the incinerator, the temperature has to be more than 500 degrees Celsius. So continuous monitoring of temperature should be there. If the temperature is less and you have a plastic inside, then maybe dioxin and furans, these carcinogens might emit from the waste, and it will be problematic not for you only, but for the whole entire globe. So then chemical treatment was there, then it was chlorine all the way. This is very handy, you know. Chlorine is all over the world, anywhere you can find it. Organic waste, burial pits were there, so burial pits were used. Heat inspection and prevention measures was also one of my duties. Infection prevention normally is the duty of doctors, but inside was the duty of the doctors, but outer peripheries and all, those were our duties as well. And we used to have a regular meeting with the medical professionals over there that decide what to do where. So, first one, isolation. That was the place where this IPC was ensured. Chlorine baths were put there for feet and shoes disinfection. Then hand hygiene practices were there. Every washing points, we had ensured that there are chemicals to wash hands that ensure you are not carrying any pathogen in your hand. Then personal protective equipment for all the health professionals and visitors as well was ensured. Waste management, as I already explained, it was there in the place. Disinfection was a regular business everywhere. Wherever anybody touches, it has to be disinfected. Likewise, water and food hygiene was maintained. Safe food, heated food. Where the WHO used to tell us, if you find a cold food, don't eat it. Be hungry for 10 hours, but don't eat it. If you can heat it, then only you eat. So that was the mantra that this right. Places where this IPC was applied. First, patient wards, of course, and hand washing stations, waste disposal zones, laundry areas, food preparation areas, transport areas. These are the places where IPC was practiced. Chlorine baths in CTCs. As I already told you that 0.2% chlorine solution has to be there for treatment. Entry and exit points. You are about to enter any CTC, there chlorine bath, get in. While coming out, you might be contaminated, and again, you stand there for 30 seconds and then move on. Patient admission areas. This is also another area from where the disease can transmit to another. Laundry areas, it has got a lot of pathogens in your laundry cloths, so you have to take care of that. Waste disposal area, another vital area, from where the waste caretakers, they will do that.